This is the first one starting in September. My name is Carolyn Shimmin. I work here at the Georgian Bay Center for Healthcare Innovations, and I work in the area of patient and public engagement. So today we're going to kind of do a little introduction to what it is and take a look at some of the methods and so on. So I'd like to, first of all, welcome everyone in the room and also everyone who is joining us via webinar today. As well, because we do have some friends online watching too. So before we start, I'd first like to start off by acknowledging that we are here today on Treaty 1 land, home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and homeland of the Métis Nation. And as we come here together today to learn, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. We recognize the ongoing present-day colonial violence in healthcare systems, in education, justice, and welfare, and government systems, and we work together in a spirit of collaboration and also social justice and health equity. And when we talk about things like patient and public engagement, it's actually Indigenous research methodologies that are way ahead of a lot, and that we should be looking to Indigenous scholars, researchers, and communities when we talk about these things. To give you an idea of what we're going to chat about today, come on in. We're going to first talk about a little bit about what is patient-oriented research. Then we're going to talk about what is patient engagement. We're going to go through some of the guiding principles that when we come together to engage, we want to think about. We're going to talk about what patient engagement is not, because sometimes we get confused. And then some of the core beliefs. And then why we should engage, which I know probably a lot of us are like, why not? Why wouldn't we engage? But we will talk about why we should, and then some of the levels of engagement, and some of the tools and resources that you might be interested in using. Oh, I have to make a disclosure because this is an accredited course. I am employed, as I said before, by the Georgian Bay Center for Healthcare as a patient and public engagement lead. So when I say the word patient-oriented research, what do you guys think about?
Research driven by patients.
Research driven by patients, I like that. Anybody else?
Yes, health outcomes important to patients.
Health outcomes that are important to patients. That's excellent. Anyone else? Mercy, is there anyone online? I don't want to leave out the ones online as well. Okay. So there's a national initiative called the Strategy for Patient-Oriented Research, and it's funded by the Canadian Institutes of Health Research. And so they define patient-oriented research as kind of like a continuum of research that involves 5 different components. The first is that it's research that engages patients as partners. And when I say partners, I mean people are actively involved at the research table helping make decisions together. Also, as we were saying, so that was kind of what you were saying, and then also we want to make sure that it focuses on patient-identified priorities. So a lot of times when we do research, it's a lot of times about what researchers want. But in patient-oriented research, we want to make sure that people who are living with health issues, caregivers, community, that we're focusing it on their priorities. It improves patient outcomes. So it has to be something that's going to improve the quality and the well-being of everyone. It's conducted by multidisciplinary teams. What that just means is a lot of times what will happen is we bring in people with lived experience, communities. We bring in healthcare workers who work with communities and decision makers. So making sure decision makers are at the table as well, because we want to make sure that they're going to implement what comes out of the research, right? So that it actually has an impact. And then that it aims to apply the knowledge generated to improve healthcare systems and practices. So that we don't just do research and publish, we actually want to actively make sure that it makes a change in us and the types of care that we get and the types of interventions that we get. What about patient engagement? What do you guys think about the patient? The Canadian Institutes of Health Research define it as the meaningful and the active involvement of people with lived experience in the governance of research. So making sure that people, communities have a say in the entire process. So meaning even on the highest levels, the steering committees, community members get a say. In the priority setting, so as we've seen before, we want to make sure that the research actually focuses on what people want to see, the changes they want to see. In the conducting of research, so a lot of times members of the community, people with lived experience, actually are actively involved in conducting the research. So perhaps they're in a qualitative research study, they're a co-researcher conducting some of that. And then the knowledge translation of research. So actively involved in how are we going to share the findings at the end and make sure that the public, make sure people with lived experience of what it means. So an organization called Involved in the UK have a great way of framing it in a way more simple way than the Canadian Institutes of Health Research. And that's, they define it as research that's carried out with or by members of the public rather than to, about, or for them. So what you've heard before, maybe from the disability community, is nothing about us without us. That is the key phrase that you've got to think about all the time, right? No research about us without our voice, without us. And here, the thing that I always try to really, really emphasize is what it means is patients, informal caregivers, communities with lived experience of a health issue actually having a say in decision-making about the research process. So having a say in what priority we should be looking at, how we should define the question, how the research should be designed, what kind of methods should we use. What kind of material should we use in the design as well? How are we going to together interpret the results? And then how are we going to actually share the results and make a change? So some of the guiding principles around patient and public engagement that we typically talk about. So the first one is inclusiveness. So when we want to do engagement, we need to always ask ourselves the following questions. Who doesn't perhaps have the same access to healthcare systems? So whether it's geographical, so urban and rural, making sure we have those different perspectives, but also thinking about some of the systemic barriers that affect people's engagement. So systemic racism, colonialism, sexism, transphobia, sizeism, sadism. So making sure that we are engaging people with lived experience that bring these different perspectives to the table. We've had times where a researcher wants to engage around dialysis or different interventions. Well, we got to make sure that people, it's not only people who are actively using dialysis, but also who doesn't have the same access and why. We need to make sure that we have those voices as well. So that interventions are not simply created for people who already have good access, but that we actually address health equities. So I always make sure when we're talking about engagement that we make sure we have diverse perspectives and that we have supports in place to make the engagement inclusive. And that when we talk about supports, we want to make sure that when we come together, we have conversations around safety. What does safety look like to us? What does it feel like to us? What does it mean to us? We need to make sure that we have that ongoing dialogue as a group. We also want to make sure that we think about things like mutual respect and partnership. That means valuing experiential knowledge that comes to the table, just like we value research expertise, and those types of things. Everything that comes to the table is so important. Co-building. This is one of the words that a lot of times when we engage, a lot of partners say this is very, very important to talk about co-building, that we're working together, that we're identifying a problem from the start together, that we're looking at gaps, that we're setting priorities, and that we're collaboratively producing and implementing solutions. Reciprocal relationship. So this is a big one. There's shared power when it comes to decision making. So sometimes when we engage as a group, we need to think about how we're going to make decisions together. Sometimes on research teams, we kind of just have discussions and then somebody says, okay, this is what we're going to do and move on. We gotta make sure that we all decide together. So using different participatory methods, come to a consensus as a team is really important. And then, of course, transparency and honesty and trust. These are essential things when we all come together. This means open conversation. It also means us taking some time to think about how we react, what are some of the different social locations that we bring, and how do we have those conversations. Conflict risk. So what are we going to do when we do disagree? Which happens, right? I think on all teams we sometimes disagree. What are we going to do to make sure that we're able to call each other out and say, you know what, I don't agree with that, and make it so that it's safe enough that we can say, you know what, I disagree, which is really important. What patient engagement is not. So a lot of times, in order to see what it is, we got to look at what it's not. One of the first things is it's not people being recruited to clinical trial or other research study to take part in the research. So people with lived experience, members of the community, are not data sets. They're actually people who are actively going to be involved in research decision-making about the process. It's not having people complete a questionnaire or participate in a focus group as part of a research study, but rather sometimes we do have what we call discussion groups around a decision that has to be made about the research process. So if you're having a discussion group around what outcome measures are the most important and that we should include in the research process, then that would be engagement. Science festivals that are open to public debate and discussions on research, again, we don't see that as really patient engagement. When we talk about patient engagement, we want two-way communication, and it has to be about decisions about the research. Again, open, like one day events at research centers. So here at the Center for Healthcare Innovation, we have like an open house where people can come and learn more about the organization. That wouldn't necessarily be seen as engagement, or raising awareness about media, or awareness about research through media and those types of things. Again, it's a great way to share information about your research project, but it wouldn't be seen as engagement per se because you're not having a conversation and you're not sharing in decision making around the process. And then dissemination of research, again, KT, amazing, important. But again, if we were to involve people with lived experience in knowledge translation and how to disseminate research findings, we would want to be actively involving people with lived experience on what methods should we use to actually share the evidence and share the findings, and how should we write about it, how should we share this information. And the core,
does that mean that there will be never kind of patient engagement in any clinical intervention? Because like from the definitions that which doesn't include in the patient engagements, I would like to know your perspective on that. But
definitely. So the question was, just for our audience online, is the question, does that mean that we wouldn't see patient engagement in any type of clinical trials or those types of things? And actually, we have some amazing examples of engaging people with lived experience in clinical trials. And what it would kind of look like is having people with lived experience actually set what the priority area should be, having them think about how to clarify and define the question. But also, we've had people with lived experience look at clinical trial protocols and say, we had one in particular where there was a study and they were giving an opioid to children, and the decision was whether to do it up the nose or through intravenous. And in the protocol, it said, well, the option is that parents could be with their kids when they get the intravenous or without, and it was up to the physician. But the parents said, you know what? I think you get better recruitment. Parents would be more willing to be part of this trial if they could be with their child during this process. So sometimes it's those little common sense pieces where you're like, oh, wait a minute, that parents kind of point out to you. Again, they actually reviewed a consent form, and they found out they had put somewhere in the consent form, they thought it was really important to let people know that the drug that they were using, ketamine, there was a short supply, so it was being taken from the veterinarian school. But the parents were like, that kind of makes me think that you're giving my kid horse tranquilizer. Like, and do we need to know this in the consent form? Is this an important part? Can we reword the consent form? So that's ways that patient partners, caregivers can actually inform the design of a clinical trial. And we now have evidence that actually when you engage people with lived experience in clinical trials, you improve recruitment. And there's been even studies now on the amount of money you save in the long run because you don't have to keep doing REBs and keep making amendments to your protocol because they have pointed out all these pieces that would improve the recruitment. So there's a lot of strong evidence that including members of the community and people at the very beginning of your study and helping them inform the design has a huge impact later on. So some of the core beliefs around engagement is that it's going to, if we engage people with lived experience at the very beginning, it's going to improve health outcomes, it's going to enhance the healthcare system, but it's also going to improve the quality of the research that we're doing, the appropriateness, the acceptability, but also the transparency. Members of the public, people with lived experience, do have a right to be engaged in health research, right? This is public taxpayers' money. They should be involved and they should be saying, this is what's important to us, and we should be concentrating on these things. And so the relevancy of the research, too. And ensuring that health research actually addresses things that are important to people that are living with a health condition. We need to be very careful, though, as I was talking before. Sometimes when we say patient engagement, it can be exclusionary. Oh, sorry, I jumped there. Exclusionary. So we have to think about also who may not identify as patient. The term itself, patient, it's not always an accessible term. So thinking about people who are unable to access the healthcare system because of geography, so people living in rural or remote. Also the systemic barriers that may impact people's ability to access things. So facing racism or systemic sexism, colonialism, all of these things that may be barriers to people's access to care. We also know that people living with health issues or substance use issues, taking up the label of patient may have associations with stigma, and so people may not really identify as a patient per se. There's also people who refuse to engage the system or prematurely exit because it's unresponsive or disrespectful care. And we also have to think about people who are living with disabilities who often are continually medicalized because they're differently able, they're being medicalized, so people may not really identify as patients. So we have to keep these things in the back of our mind to make sure that we address all of these barriers when we're going to bring people together, because we want people who also don't identify as patients and we want inclusive practice. So these are important to think about. Why should we engage? Well, it's important to, first of all, people with lived experience have amazing insight into what priorities should be looked at. There's been a study before, there's an example where there's a study on rheumatoid arthritis, and researchers thought pain management is the number one thing that people living with rheumatoid arthritis that's like what they really want to be able to look at. And then they engaged a bunch of people living with rheumatoid arthritis, and they found out it was actually the fatigue that's associated with rheumatoid arthritis. I'm too tired to go to work, I'm having those issues. And so they changed their entire research study because they realized what they were looking at wasn't what people living with that experience actually thought was a priority. So by engaging, they found that out. Also helping to shape and clarify research questions. We had an example, there was a study around mental health, and they engaged people with lived experience of mental health issues, and from that engagement, they realized the way in which they were looking at the research question was all about looking at the challenges and the struggles, and people with lived experience said, can we flip it? Can we rename the study? Can we look at it from a strengths-based approach? Can we talk about recovery? Let's talk about resiliency. Let's look at those aspects instead. And so they started to recraft it. What happened was they were able to engage way more people with lived experience because it was from a strengths-based approach, and people were like, yeah, I think this is what I want to see versus from kind of a negative approach or deficit approach. Also ensuring that the methods that are being used when we do research actually are appropriate, they're acceptable, they're sensitive to the real context of people with lived experience, the informal caregivers, communities as well. I was trying to think of the one, there was a chronic pain study where they had created this survey tool, and it was a really lengthy survey tool that was supposed to be administered over the phone. So they brought all these people together who were living with chronic pain, and they said, there's no way that this long phone conversation is really going to work for us. We are living with chronic pain, we don't want to do something like that. So the people with lived experience helped recraft the survey, shortened it, of course. They redesigned the tool so that it was around self-reported and it was a self-paced thing as well, so you could answer when the time worked best. And so it facilitated better ease of participation, and so more people wanted to become involved, which was very important. Making sure that it's also important to engage people to make sure that the outcomes that you're using in a research study actually have meaning to the people living with it. There was a study where they were engaging around prescription drug use for people who had just experienced a stroke. And so stroke survivors were brought together, and the study, they realized one of the most important things for people with lived experience was home time, the amount of time that we would be at home versus the amount of time that we were in the hospital. And meanwhile, the researchers said, okay, the best measure would be how long we're at the hospital. But home time was really important. So just making sure that the outcomes are what people want to think are really important. And then again, making sure that the language and the content of the information that's being provided to perhaps participants in the study is appropriate and accessible, so questionnaires, and we've seen that time and time again. Consent forms, questionnaires, all of those things, if they're not written in an accessible way, they're not asking questions in the right way that people can understand, it's really important to engage people ahead of time. And again, the part that we were talking before around the clinical trials is increasing the research study by making all of these types of materials more accessible, understandable, and that voices traditionally less heard are included in these materials as well. Again, it's really important, even at the end stages of research, that, that we actively engage people on how should we actually disseminate the findings at the very end. And there was an interesting study where it was a pragmatic study around chronic pain, and physical therapists partnered with the study to design a continuing education program that came out of the findings, but people living with chronic pain were actually able to inform that continuing education program so that it was responsive to the needs of people as well. So that was very important. And then to identify a wider set of research topics or new areas of research. A number of times we've had researchers say after the fact, I engage people with lived experience, and now I have this whole other area of research that I hadn't thought about before. We had somebody who was engaging people in an international clinical trial around sepsis and didn't realize that one of the top priorities of people who have cirrhotic sepsis is frailty. They never realized that this might be an area that really needs to be addressed. And then from there, it developed a whole other area of research with community members, people who had experience. Interpreting the research findings is really important as well. The number of times where at the end, I think, Ogai, you had a study once where they brought together a bunch of different people with lived experience, youth with rheumatoid arthritis, and brought together educators, and from that, they all came together and built different tools and interventions that will be important for people with lived experience based on the research. In the very end, of course, that research actually reflects the concerns and interests and values of people, and that money and resources are used efficiently. I don't know if many of you have probably already heard this before, but there's kind of different levels of engagement seen as a spectrum. So it goes from consultation all the way to patient and public directed. At the consultation level, this is the lowest level of engagement. It's considered, this is where health researchers engage with people with lived experience to find out, to give some feedback on a research decision. The thing is, researchers still maintain a lot of the decision-making power. That's why it's seen as the lowest level of engagement. And oftentimes I find researchers kind of start at this area and through the process will move towards patient-directed over time. Some of the participatory approaches that you might use, a lot of times advisory councils or groups are great for helping inform research decisions. Discussion groups, interviews, public and town halls, those types of things can be great ways to find out what people think about research decisions. At the collaborate level, this is where we're actively partnering together. So researchers and people with lived experience. And this means everyone's sitting on the same team and there's shared decision-making power and making decisions together. And there's a lot of different participatory approaches, whether it's digital storytelling, world cafes, all of these types of ways of bringing people together to make decisions. Now, the highest level of engagement is actually patient or public directed. And this means members of the community, patients, caregivers, actively control, direct, and manage the research project. All decision-making with regard to the research process is being made by patients and caregivers and communities. And in this way, the role of the researcher kind of changes. They might be there to provide support while people with lived experience are actively conducting. They may be there for advice, training, or they may carry out the research project under the direction of members of the community. And so that's where we get into participatory design and those types of decision-making. And there is a tool, I think after, maybe we can email everyone afterwards some of our tools and resources. There's actually this little map online that we have on our website where you can actually look at all the different phases and stages of the research process, click on one phase, and then you'll find out, and then you have an option of what level of engagement, Then when you click on that, it comes up with a bunch of suggestions on what participatory approach you might want to use. And then if you click on the participatory approach, it gives you this big write-up around why you would use this approach, when it would be appropriate, and then here are some additional resources as well. So it comes in handy sometimes when you're starting to think about, okay, I think I want to do this, what would be the best way, or what are things that I should consider when I'm engaging. And when you're starting to think about engagement, it's really important, first of all, to start assessing some of the expectations and the willingness around engagement. So internally, researchers need to ask themselves things like, what is the minimum required level of engagement for this grant application? So if you were applying to a SPOR or strategy for patient-oriented research grant through the Canadian Institutes of Health Research, you would want to be at a collaborate level or a patient direct. So you want a high level of engagement. This is the most important thing. You wouldn't want to be at a console level. To what extent researchers have to have those hard conversations. What extent does the team believe that engagement will improve the outcome? What's the potential? Where are the decisions where people can have a say? And that means researchers have to be flexible. And if patients say, no, that I don't think that's important, they have to be willing to share some of that decision-making power. So thinking about where I do want to engage, what the potential for people to engage is, what is the likelihood that we're going to consider everybody's perspectives, and then what resources do we have to support? That's a big one. Building a budget for engagement is really important. People with lived experience who come to the table should be compensated for their time, their energy, their insight. They're coming and giving you this incredible knowledge. Payment is important. Supports as well to make sure that people can come to the table, like caregiving costs, care attendance as well, making sure you have assistive devices, making sure the space is accessible, all of these things, transportation, making sure that all of these things are covered up front so it doesn't have to be an expense for people with lived experience. And then one of our big things here is we talk about critical reflexive practice. So that means each one of us, whether we're researchers or patient partners, it's important to think about what my personal values are, experiences, interests, beliefs, and political commitments around the area of health research that we'll be looking at. We sometimes have researchers say, well, when I engage people with lived experience, they're advocates and they have political commitments and stuff like that. But researchers do too. They bring their own social location, their own perspective as well, and their biases as well. So it's important to have that critical reflection. Also understanding where those personal experiences relate to larger social locations and systems of power and oppression, and understanding how that affects the area of health that you're researching, and how are we going to, when we come together, think about those power imbalances and we negotiate them. So thinking also about what your personal values, assumptions, perspectives, and experiences are regarding to the people that you are engaging, and thinking about one of the biggest things I always say with patient-public engagement, it has to use the social justice and health and equity lens. We have to think about what current health and equities exist with regard to the area of health that we're researching in, and how are we going to improve those and make a change. And we have an article that I can share a link to as well, perhaps after, if you signed with your email address, and it actually has questions for research teams and patient partners when they come together to think about around safety, around trauma-informed pieces, and around like how we have those difficult conversations. And it's called Moving Towards a More Inclusive Patient Involvement in Health Research Paradigm, the Incorporation of a Trauma Intersectional Analysis. once we do the internal, we also have to start talking to people with lived experience. Before we even decide how we're gonna engage, we need to talk to people to find out how people would prefer to be engaged. So thinking about previous history of engagement, if people with lived experience have had negative experiences of engagement, understanding what that means and how those things will have to be addressed. Again, what inequities exist, so who's affected differently, who has different access. Understanding what the values and expectations of people that you want to engage is going to be. How do they want to be engaged? What are their expectations of you as a researcher? And then what level do people expect to be engaged? Sometimes we have researchers who are kind of like, oh, we'll just do the consult level, but members of the public or people with lived experience will say, I want to collaborate or nothing. So then you've got to decide and have those conversations around how to negotiate that. How would people prefer to be? For the Center for Healthcare Innovation, I know this has been a lot of information for an introductory session, but we have a few resources and services that are always available to everyone. We have free 1-hour consults, so if you're ever thinking about a project or thinking about ways to engage, we can go for coffee, we can have a conversation, we can talk about what you like to see or whether you want to be connected with other groups. We also have a blog, it's on Medium, and it's called Knowledge Nudge, and it has a whole section on patient and public engagement. I think we have over 30 posts now on patient engagement, and it goes from everything, so some of the basics about levels of engagement and participatory approaches, but then it also talks about trauma-informed engagement, how do we talk about safety, how do we deal with conflict, so it's a really great resource. We also have this monthly lunchtime learning series. It happened every month, the second Wednesday, I have to think about that, the second Wednesday of the month, over the noon hour, and everyone's always welcome to attend. I think some of our upcoming ones are actual case studies, so people who have engaged communities, and so community partners and health researchers talking about what that experience looked like, some of the challenges, but also some of the successes as well. As I showed you before, the online mapping tool we've got. We also have a budgeting tool that can be really useful if you're writing a grant or just trying to think about how much should I budget for to bring everyone together or to do engagement. It actually calculates things and tells you how to do it. So I think we can send those links as well. Twice a year we have an award, and the award is open to health researchers, community organizations, and students. And it's for engaging at the very, very early stages of the research process. We found out that a lot of researchers struggle with engagement at the early stages because they don't have any funding or don't have any resources available. So this is a little award that you can apply to. They'll help you, and there's some in-kind supports from us as well. And then we have an amazing collaborative partnership. It's a group of people, I think it's 13 diverse Manitobans that come together every 2 months, and they are engaged not only around the organization, but also sometimes researchers can ask to come and present to them. Not present to them, but rather share what they're up to and then ask for their advice on, say, I'm thinking I want to engage people around outcome measures, what's the best approach, and our community members are amazing. They're able to say, this is what you got to do, this is where you got to think about, so they're wonderful to engage. And we have a champions program that involves different people who work on engagement that come together once a month and have conversations around some of the successes and challenges as well. So that's lots of information. I feel like I've been just talking so much. How about we open it up to questions? Does anyone have any questions? Even experiences with engagement? Have any of you guys engaged partners before in your work?
I have a question.
Yes.
If you're doing a prevalence study, okay, where would you see it? Are you looking at administrative data? So where would you see patient engagement operate in that kind of
That's a really interesting thing we're actually trying to tackle right now around administrative data and how do we get people involved in that kind of thing. And even we're starting to think with our advisory group how to co-design training, like just what is an accessible way to talk about data and to explain things like, well, we take this kind of information and move forward. But what we're finding is people with lived experience still are able to give a lot of really interesting input from the design perspective, but also just on things that you might want to consider when you're looking at the data as well.
What type of questions you might want to ask?
Yeah, questions you want to ask, because sometimes you can say, okay, this is everything that we can get from the data. Now, what kind of questions do you think are really important when we're looking at it? And it's amazing sometimes the questions that come out of, because they're not looking from that research lens. They're able to say, well, this is something that's super important to me as whether a member of the public or whether a person with lived experience or a caregiver in my community would love to know this question, and it could open you up to like a whole other research study. And we can, definitely share if we come up with any like lay terminology around data and complex data and all those types of.
I actually did include a patient partner. I do psychiatric epidemiological research.
Oh, I think that's a lot.
Oh, okay, yeah. And
Exactly.
so, I did include a patient partner for my population-based studies, and I had them look at the survey. And what I was interested in is outcomes of comorbidity of PTSD and substance use disorders.
Okay.
And I had them sort of reflect on some of the outcomes that I was interested in looking at. And they interestingly suggested, they said, Renee, you're looking at all of these really bad outcomes like suicide and disability. What about the people who do well with comorbidity? And it really sort of opened, and I was like, yeah, I guess so. And so I started looking, or we're planning on looking at more resiliency factors and what predicts the positive outcomes in sort of a situation like that. So that was sort of an example of how a patient partner influenced my epidemiological research.
All right, thank you.
Wow, that's amazing. That's great to hear that, and the amount of amazing other questions you came up with. Oh, Mercy.
I have a question from Louise
Okay.
from Beverly. She asks, curious what kinds of attributes in your experience of leadership have helped you contribute to the depth of PE in your life?
What kind of attributes? Oh, this is a good question, Beverly. So can you repeat it?
Yeah.
Sorry.
So what kinds of attributes in your experience of leadership have helped contribute to the depth of PE in your organization?
In our organization? That's a great question, Beverly. It's interesting. We have just completed a study where we engage people with lived experience around what kind of attribute they would want from from researchers and so on. What are really important skills to bring to the table when you're engaging? And so some of those pieces were those skills, those things that we don't talk about and we don't really train in research that are so important. Things around empathy, around relationship building and trust, around strengths-based ideas, around trauma-informed approaches, around being able to critically reflect as a researcher, as a decision maker, when you're coming to the table about your own social location, the locations in which you inhabit, and how that may affect the way you view things and the way you talk with one another, and having ongoing dialogues around things like safety are so, so important. And so many times with engagement, we don't think about that. We just come together like it's just another research meeting without having those conversations around what makes us feel safe together. We also have a lot of conversations too around the importance of self-care, not only when it comes to the patient partners who are being engaged and who are engaging, but also health researchers need to understand too, the importance of things self-care, because sometimes you're asked to bear witness to a story that may be really difficult, and these are people's real lived experiences. And so at the end of the day, you also need to have supports in place as well for yourself. I think that makes an incredible leader in this kind of thing, to be able to recognize when there's a need for self-care, also recognize when you're being called to bear witness to somebody's story, and making sure you take the space, take the time out. I've had times where I know within my day, you're going about your day, you're doing all sorts of things, and one of the patients who have been engaged on a research project drops by, is just having a tough day. You need to stop what you're doing and make that space to be able to bear witness and to listen. Active listening is so important. Making sure that you uphold that space and make that space for people to really be able to share their experiences, and being able to provide resources. I know when we engage, we always have a list of supports as well for people who when they're experiencing their story, may just need some extra supports after you engage, and making sure those are in place, that people are feeling safe throughout. So those are some of the things that we've discovered along the way that are super important. Thank you for that question. Yes.
Thank you for this. It was really interesting and helpful. So my question is that what would be a good strategy or suggestion to find patients and engage on your research that we're going to have? Because I find sometimes like as researchers we may be biased, or we may have connections and then find patients in that way. But I'm not sure if that would be the best way. So based on your experience, what do you recommend?
That's a good question. We get a lot of those questions sometimes around recruitment and how do I choose, or which ways to engage. And it's really important because sometimes we just don't know where to even begin, right? Do I put a poster on the wall? Do I figure this out? Some of the great ways that we've over the years kind of found help is connecting and building relationships with community organizations. We've had relationships in the past where we talked to mental health organizations like Clinic or the Canadian, and ask them, what is the best way for me to identify people who might be willing to become engaged? Sometimes it's thinking out of the box as well. So you may be engaging around a certain topic, say type 2 diabetes and so on, and you may say, okay, I just need to go to the Diabetes Association of Canada and I'll recruit that way. You may end up getting kind of people who have fairly good access to the system, and all that kind of stuff. And so it's important to think outside of the box and say, maybe some of the community organizations in my area, I should touch base with them as well in case they know someone who may be interested. Talking to other researchers who have done community engagement in the past and say, how do you think I could connect with people? It's really recruitment strategies are very depending on the group of people you want to engage. So we've had experiences where you're engaging in rural and remote. Maybe it's being on a radio show and talking about the project, or maybe it's a little ad in a local newspaper. So there's all these different ways. So it all is, I know it's kind of one of those answers that's like, there's so many out. But I think a lot depends on who you want to engage, and thinking outside of the box as well as far as engagement. Connecting to community leaders is really important, because a lot of times people can identify or help you identify the best way to connect with people.
And also, the relationships are key, and just being out there in the community yourself. Trust is huge, and you want to build relationships with people, so community members can see who you are, learn a little bit about your research. They have a chance to ask questions. I know when I did a photo voice project, I would go present at any organization that I could, and then sit and have coffee or tea with whoever that had further questions for me, so they get to know who I am as a person and as an individual. Online is also a new space for people who may not have access to any community organizations. Radio is a really good one for rural communities. Yeah, and if once you find a few people, the best way is to then engage with them, and they might come up with some really good strategies that we didn't even think about to begin with. So engagement also comes in play, and that's no problem.
And that's a great point too around relationship buildings. I know someone who does research with people who are seniors or elderly frail, and she actually doesn't have a research project right now, but she still goes and has coffee with people just to start building those relationships and talk about what priorities are important to people. So then if there comes an opportunity to do a project together, you've already had some of those conversations. And the two-way is important as well, right? Engaging community members is super important, but also sometimes if a community group is having an event, going out and supporting it, bringing your family and making sure that you also support and there's benefits on the other side. Making yourself, helping out with some of the events as well, and kind of making sure that you build those relationships.
So I'm kind of getting a sense, I work in the hospital,
Okay.
so I kind of have, hospital vision or whatever, where my perimeter sort of ends.
At the hospital. Yeah.
Although I've worked in the community for years, so I get all of this, but if you're within a hospital setting and trying to, have research happen, then there's so many layers, right, to patient engagement. Like, it's very difficult for me as a clinician, because I'm a clinician, is to go out and have coffee and do this kind of things.
Right.
So my understanding, and I'm just kind of, is there now, I think some programs have patient advisory groups, so.
More and more, yeah, they're building these kind of advisory groups that you can then go and have conversations with around things.
So then that's how you would do engagement, although I would like to see a time where it's more fluid between hospital and community, that we don't, because in my philosophy, hospital is part of the community.
Yeah.
But we still have this division. Right?
Yeah. And I guess you have lots of things around privacy and all those pieces of the puzzle as well. The interesting thing is I think there are some projects going on around that right now where they're bringing public members together with health researchers and hospitals around privacy and those issues and how do we overcome it. Because sometimes members of the public think that you're able to kind of identify, say, hey, do you want to go for coffee night, but not realizing the number of barriers to that kind of thing. So I think there's more and more conversations around ethics, around the privacy piece as well. So how do I, as a clinician researcher, identify people, especially in areas I know we've had times where if it's a rare health condition, and you're a clinician researcher, there's probably everyone who is experiencing it is one of your patients themselves. And then, so how do I engage people with lived experience and also making sure that they know it's not going to impact their care at all if they disagree with me or they think I should be doing something else. So it's those pieces of the puzzle that are slowly starting to be addressed because they're huge barriers as well.
And you could miss a large segment of clients who could be impacted by that type of research, right?
Yeah.
Like I work in mental health, a large, I don't know the stats, but just from my own senses, so many people are still served by the hospital system, right? So if you're doing research that is just sort of community focused, you're going to miss a huge segment of those people.
Yeah, where you actually can't engage with people that you know are within the system. So it is it's a thing I think over time ethics boards and the privacy people from the regional health authority, I think there's more and more conversations around that. How do we do meaningful research where we can actually engage people without having all of these barriers in place? Because I'm sure you talk to people every day and that you would love to engage in your actual work. hoping we slowly inch towards that progress. Are there any other questions? Mercy, we're going
No, but just a lot of great insights and how the Knowledge Edge blog and our online resources have helped other SPOR support units like the support group. So I just wanted to say thank you.
Thank you for using that. That's always great to hear. And I'll make sure that everyone who came today also will send out a link with all of those different resources that you can access. And always feel free, of course, you can always email me or tweet at me if you have questions. I'm always around. Feel free to contact me anytime. We have an amazing team. Guys is one of our wonderful members as well, that we work in patient engagement, and we are always free to go for coffee. We love to go for coffee, and we love to. And also online, we're always free if you want to have a phone conversation about some of the resources or the tools, or you have a question, we're around. So definitely feel free to ask us. Thank you so, so much for coming today. I'm so glad to have all of you here and to have this good conversation. Please check out next month's Lunchtime Learning. I think it's a case study, but we'll make sure to let you know. I think we send out lots of emails. Thank you so much, everyone. Thanks.